Good day, and welcome to today's NIC Leadership Huddle, Telehealth's tipping point, the new norm in care, and how to build for success. This is the 7th Leadership Huddle of our 2021 webinar series. I'm Chuck Carey, NIC's Chief Operating Officer, and I have just one quick comment regarding the webinar's logistics ahead of our panel's discussion. If you need to adjust your audio for today's webinar, you have joined the webinar using either your computer speaker system or your phone based on your audio access during your most recent GoToWebinar session. You can adjust your audio access to today's webinar through either your computer speakers or your phone using the settings in the audio pane, which is located on the top of the control panel on the right side of your browser window. Moving to our panel discussion, it's my pleasure to introduce my NIC colleague and host of today's Leadership Huddle, Ryan Brooks, Senior Principal with NIC, whose research and analytics contributions span the areas of healthcare collaboration and partnerships, telemedicine implementation, EHR optimization, value-added care transition, as well as regulatory and payer environments. Ryan, we look forward to the panel's insights regarding the value of integrating telehealth into your business model.
Thank you, Chuck, for the introduction. Good afternoon, everyone, or good morning, depending on where you're joining from. I think we would all agree that the COVID-19 crisis pushed us into the world of telehealth quickly. In many ways, it became the tool of choice during the pandemic, as it was an effective way to keep individuals, care providers, and staff safe. I believe that the care delivery via telehealth will be integral to our sector's future. I think it's important to remember that telehealth is not a solution for everything, but the last year has taught us that it is a solution for a lot more than we may have previously thought, and it's a valuable tool to have in our toolbox. Now, generally speaking, telehealth services increase access to primary care, it increases access to urgent care, and it also improves collaboration and efficiency among long-term care, dialysis centers, clinics, and many other provider locations. The timing of this conversation really couldn't be more appropriate. As we speak, the House Ways and Means Health Subcommittee is beginning their hearing titled Charting the Path Forward for Telehealth, where they will be examining what needs to be done from the regulatory and legislative perspectives to sustain the current momentum of telehealth. Before we start today's discussion, let me introduce our subject matter experts. First, we have Pam Ferris. Pam is President and CEO of Seacrest Village, a multi-level senior living community in Encinitas, California. She joined the organization in 1989, overseeing the operations before her appointment as President and CEO in 2000. Josh Hofmeyer is a licensed long-term care administrator and is currently serving as Senior Care Officer for Avera eCARE, overseeing telehealth services operating in nearly 200 locations across the country. Michael Kurliand is the Director of Telehealth and Process Development for West Health and has worked in healthcare for 25 years, previously serving as both a clinician and an administrator. Welcome, everyone.
Thank you.
Thank you.
Mike, do you want to kick us off?
Sure. Thank you, Ryan, Chuck. Thank you for opening and introduction. A pleasure to be here with my fellow panelists, Pam and Josh. Look forward to the dialogue. And thank you to the attendees. I wanted to just open up by providing a little bit of context because you've probably heard a lot of telehealth this, a lot of telehealth that, especially this past year. But I wanted to give you some information that might be helpful, kind of like painting like the longer term picture and like why telehealth was starting to really pick up momentum when it did outside of COVID. So you're probably aware more than most that each day that passes, 10,000 boomers are turning 65. And that's going to happen every day until 2030. What's really more outstanding to me and reminds me of just how like time flies is that the oldest boomers are starting to turn 75, right? People are living longer, and that's great, but they're living longer with multiple disease processes. If you look at this slide, it's like, oh, I'm sorry, the next slide. Bear with me, folks. So if you're looking at this slide now, like you may be surprised that by 2030, PCPs are going to be down about 40,000 plus in the United States, and specialists are going to go down probably to at least 30,000. And for nurses, depending on what state you're in, you might be okay or you may be short. The jury's still out depending upon, you know, what study you're looking at. There's just conflicting findings, but as a nurse myself, I always felt that there was never enough of us, and it always contributed to some form of burnout. So if you look at those numbers, they're eye openers. And what really makes me worried is that the number of unpaid caregivers is going to be cut almost in half. These are the unpaid family and friends that help the loved one or the family member. That number is going down from 7 to 1, I think that was back in 2010, to 4 to 1 per person. It's hard enough waiting for weeks or months for specialty appointments, but that pales in comparison to having even one less caregiver. And I don't know if you've ever had to take care of somebody, but it does take the entire family and friends to really help make sure that things don't fall through the gaps and the person is receiving the care that they deserve. And this is all happening before COVID-19. Next slide, please. So keeping a lot of folks up at night also is the cost of healthcare. Families here in the US live with the world's costliest healthcare, and it ranks around the 30th in the entire world, which is complete craziness to me, especially since I've been in healthcare for 2.5 decades. Like, I still find that just absurd that we're so far down and it's so expensive. About half of adults are scared that a major health issue in the household is going to lead to bankruptcy. So I went to this website. You know, it's actually sponsored by West Health. I suggest that you go to it, and it was up before COVID-19 and the pandemic. So the numbers here might be a little bit dated because they don't take COVID-19 into account. And there's a calculator on the web page, and I did out of curiosity, and it figures out my anticipated out-of-pocket expenses and what my employer's anticipated expenses will be for 2030. The average household will be spending $14,000 for healthcare per year starting 2030, and employers, for all the employers, and Pam, this might make you like, oh my goodness, will be spending close to $22,000 per employee in 2030. That's a lot of money. So something's got to give. So you have to look at other alternatives. So part of the strategy of decreasing the cost of healthcare is finding and implementing lower cost alternatives. And like Ryan said earlier, telehealth is not a silver bullet, but it does represent a viable alternative to certain types of visits and encounters. Telehealth can allow the provider to see patients that have low acuity issues in the comfort of the patient's own home, which would allow the patient to theoretically, have easier access, presumably giving attention to an issue sooner than later. I don't know how many folks have kind of like waited to go see somebody, but the longer you wait, the worse things typically get. Now, if you fold in the example and the reality of COVID-19, there have been numerous reports of self-rationed care. People are just scared to get out. People don't want to. Thankfully, with the vaccine in place, maybe that's not happening as much. But back last year, especially, that had led to many, many poor outcomes and even deaths. So with telehealth, you could see people before they get worse. And the provider also gets something out of this. They get to use their physical footprint of their location for more high acuity and more revenue driving visits. Regardless whether if you're leaning into telehealth or not, healthcare costs were unsustainable before COVID-19. CMS knows this, they see this, and they're going to make changes. My personal guess, based on just kind of like what I know of the industry, is like I don't think CMS is going to do anything significant in the next 2-3 years regarding reimbursement, but expect that it's going to happen because just things are unsustainable. In defense, you're probably going to see a lot of organizations do value-based care models. Like you're going to see a proliferation of them, which value-based care models are the perfect, they're perfect for telehealth, and they're a very good shielding strategy. In these models, you get paid basically per member per month as opposed to the fee-for-service or for the volume. It guarantees money coming in per month. You're also going to see more people self-steer themselves to lower cost healthcare. Like if you're on the hook for more cost, you're probably going to self-steer yourself to more lower cost alternatives. So if you're a healthcare organization or you're thinking about partnering one, it's not too late. Telehealth arrangements, they take all shapes and sizes. It's new. It's worth having these discussions and seeing what opportunities there are for creative and mutually beneficial relationships. Next slide, please. So before COVID-19, if you would have asked me what the most important reasons for telehealth, I would have said, like, it makes access to care easier and more convenient. It's timelier. Patients are more satisfied because the care is brought to them and not bringing them to the care. And for the early adopters like Avera, there's much greater market distinction at minimum. But now the overarching reason really is safety. Patients and staff really want to be safe. So avoiding unnecessary contact with potential exposure was the driving force for telehealth growth. Next slide, please. So right now, we've all lived through the telehealth tipping point. You've seen it, you're still living through it. But right now, it's kind of like the implementation's been more like a blunt object. People have just had to like slam it in to get by. We're not anywhere near a renaissance for telehealth. It'll get here eventually, but most of us are still figuring out how to use it. And, you know, organizations did what they needed to do to get by during the pandemic, but the dust is settling now. And organizations are taking a long, hard look at the ROI, the opportunities, the operational impacts, and the regulatory environment to really determine like how and when they are going to use telehealth, which is very good. At least it is in the conversation now. So next slide. Worried about running out of time. I could talk forever. So a little more context. Over the years, like CMS made some minor telehealth reimbursement adjustments, but the cost of operationalizing telehealth didn't really outweigh the challenges. So what you saw was almost nothing. Little utilization, actually little is putting it lightly. So there was almost zero. Prior to COVID-19, only I'm going to say it again, 0.1% of Medicare beneficiaries use telehealth. 0.1%. That's not even 1%. Get me started. So in comes COVID-19 and virtual care literally skyrockets. From a regulatory perspective, this was really enabled by the March 2020 CARES Act. It temporarily lifted many of the archaic limitations, specifically around the geographic limitations and what kind of providers you can use for telehealth. And the number now still blows my mind because I've been doing telehealth for about 7-8 years now. Between mid-March and mid-October of 2020, 39% of Medicare beneficiaries received telehealth service. Think about that, folks. In just 7 months, we went from 0.1% to 39%. I gotta say that no one knows where the new normal will land with telehealth. Some are saying that they're gonna do like about 15 to 20% of all their visits will be telehealth. But if you talk to Kaiser, they're saying no, at least 50% of our visits are gonna be telehealth, and we're gonna, you know, use our footprint for the most serious cases. By the way, no one knows the new normal for in-person visits as well. So it's all speculation, folks. Next slide, please. So surprising to many, investments were and still happening. Prior to 2010, hardly any VC money went to healthcare tech, which was a surprise to me. But by 2018, 17 billion of capital was going to healthcare startups. So now you have a more favorable regulatory environment, more interoperability, and the user experience is getting better. And so in general, not telehealth, but health tech is maturing, and it's being more and more sought after as a potential investment. And if you've been watching and listening to this administration and our previous administration, there's an expectation that many of the regulatory flexibilities introduced during COVID will evolve, but will be here to stay. So there's a lot of consolidation happening, but most importantly, I think for this group, is that the relationships are evolving. Provider organizations are going to try to be more creative at increasing their patient headcount, as well as preparing themselves for more of a value-based scenario. So right now you're kind of like in this world of like one foot on the canoe, one foot on the dock, yes, but that does force some creativity. You'll be surprised at the balance that you get when you have to have one foot in each location. So there's a lot of opportunity there if you are willing to have that dialogue with some of these companies that do telehealth. Next slide, please. Let's see. You know what, real quick about this slide, because I think I'm running out of time. So in general, whenever you're being innovative at your organization, you have to be iterative and just kind of keep this in your mindset that things aren't going to be exactly right the first time out, and you need to be patient, because when you're incorporating something new into like how you deliver care to a patient or a resident, things are going to happen that you didn't plan for. Just stick with it, because if you don't, you're going to eventually have to deal with the inevitability of dealing with some other, like with telehealth, honestly. Next slide, please. This is really my last slide, folks. And then I pass the baton over to Josh. So telehealth's really seen a lot of attention, and rightly so, in the last year. What we're going to continue to see is more of like this hybrid care delivery model, basically blending virtual care with in-person care. But folks, these models need to be done by purpose, not by reflex. And this last year, we did a lot by reflex. Since the pandemic, patients and caregivers, have experienced a lot more virtual care. So people are getting acquainted with it, if not already used to it. So all the stuff that the context that I'm giving you, these are factors that all combined, they really do present an opportunity to rethink how you deliver care and have relationships and partnerships with other organizations. So it really is time to rethink how you deliver care, because if we've seen anything this last year, it's better to be prepared than be reflexive. Thank you, folks. Next slide.
Michael, thank you so much, Mike, for that great overview and context. Why don't we turn it over to Josh? Josh, maybe you can go into a little more detail about right-sizing telehealth programs.
Yeah, absolutely. Thanks, everyone, and great to be here with you today. Avera eCARE has been in the telehealth market for over 27 years, and so we've used those years to really learn and figure out what can be successful and what can work across a variety of settings, anything from hospitals to schools to prisons to direct-to-consumer to especially the senior care settings, whether it be skilled nursing or long-term care or assisted living, doing some work in independent living now as well as home health. So the market certainly has changed in the last year, and we've had to pivot a couple of times. But at the end of the day, whether there's a pandemic or there's not, there's still a lot of really good reasons to be looking at telehealth as a solution for healthcare providers. There's a lot of benefits for it, not only for the providers, but also for residents and staff and different things. And I'll talk a little bit more about that here in a little bit. But first, I wanted to talk just a little bit on this next slide about, really how does telehealth work? And again, it can be a variety of different ways. Our model is one of many. that are out there across the country. And even within our model, we have many different stages and options and things that groups can come to us for, because you never do know exactly what the needs are, and we want to be able to help support whatever those are. And so I think one thing I would talk about as you're looking at telehealth as a solution and the new wave of the future is, think broadly at first. Really think about what are your needs and what is it that you need to be doing, and where are your gaps, and then take a look at telehealth and figure out where can that work, where can that help fill in those gaps, where can it help meet those needs. We're very team focused in everything that we do and in the programs that we have created. So we have everything from board certified geriatricians to 24/7 urgent care providers that work on our team. We have a pharmacy component, a psychiatry component, wound care component, social workers who really work on things such as palliative care, hospice referrals, and then care transitions programs, as well as we look at making sure that people get from point A to point B without having a whole lot of issues, because those transitions can be hard. And that's where a lot of gaps can happen as well when you're providing care, is when those people you care for are going from home to the hospital, or hospital to home, or hospital to skilled nursing. And really being able to support them during those times is key, because a lot of things can get missed and a lot of things can happen. And so knowing what type of program you want and going about finding that programming and implementing it is important. And as part of that too, you really have to be thinking about the right technology, and that plays hand in hand with what type of program you're looking for. If you're strictly doing something that's psychiatry only and only going to be video to video conversations, you don't need the same type of setup as someone who's going to be looking more for that clinical support, that urgent care component, where you're going to want some of those peripherals and different things involved. And so, some of the biggest steps are doing a needs assessment and really figuring out what those needs are, and then determining, okay, where do we go from here? And for our organization, we have spent years looking at technology options, and we have a couple that I would call are our favorites that we typically will utilize based off of what a customer might need. But those aren't necessarily always the right solution for everybody, although they do seem to work in many cases as we're looking at this. So once you do that needs assessment, figure out what you need, go about getting that, obtaining the technology, making sure you have the right components of a program. Then it's really about looking at the outcomes. And my next couple actually are going to talk a little bit about this, but on the next slide in particular, looking at some of those initial outcomes. And what's also important as you go about this work is not only figuring out what your needs are, but then tying that into how do we know if we're making an impact on those needs? What are we trying to do? What are our goals? What are our objectives? And how do we then monitor that? Some of the things we see most commonly when we're working with the couple of hundred of locations that we work with on a daily basis that they're looking for are improved transfer rates. They want to cut back on those unnecessary transfers. They want to cut back on those emergency department visits that typically result in an emergency department visit and then the person comes back. They want to cut back on unnecessary rehospitalizations if that's possible. At times, transfers have to happen. Rehospitalizations have to happen. We cannot cut back on all of that, but we all do know that there are impacts that we can make in those areas. And so those are big areas that our partners typically will focus in on. And you can see here, if you roll out the right telehealth program, you can see improvements on those 30-day readmission rates and those unplanned transfer rates, up to 62% reduction in unplanned transfer rate. Another big thing people look at is how often can we treat someone late? Avoid that going out and coming back. It's not good for anyone to constantly be going between points of care, especially when you're talking about the elderly. And then if you throw a diagnosis of dementia onto that person, it really gets to become complicated. And so the more often we can treat someone in place, keep them at where they notice as home, the better off that can be. And so being able to hit those impacts of, over 90, 96% of the time treating someone in place, it is a big deal. On the other side of the slide here, you can see, estimated Medicare cost savings. We did a study on that to impact total cost of care. We've looked at, reducing the overall hospital admissions, as I talked about, looking at occupancy rates. You'll see here that we talked about an increased length of stay. Overall, when we're working with Medicare populations, we'll help get them back home sooner if that's what the goal is. But sometimes we're just looking at like an assisted living or long-term care populations, and they're looking to try and stabilize their census and keep people in place. And we can increase that length of stay then in those instances by not having those people transferring out. And then where do they go from there? And I was managing assisted living. I can't even count the amount of times where we didn't have the access we needed to clinical help. So we would transfer our resident to the hospital, and the next thing we knew, they were going across town to a skilled nursing facility, and we never saw them again. And that's very common because that's the care that, the path of care that those people take. And that's not needed if we have the right access and the right things in place. We're able to help stop some of that. The last note I'll make on here is just that overall increased staff satisfaction. One of the biggest things that telehealth can do is it can really help improve the satisfaction of not only your residents, but also your staff, to make sure that your staff are happy in what they're doing. My next couple of slides here, I know I'm coming up on time, so I'll just briefly highlight, focus really in on specific benefits and things that you can be looking for as you're implementing telehealth. When we look at residents, improved access, enhancing the quality of care and their quality of life, being able to treat them earlier and more often, decreasing those unnecessary transfers and hospitalizations is important. On the next slide, we focus in on what are the benefits when we talk about primary care providers. We're able to help support a collegial relationship with them, communicate care updates, help fill in a lot of gaps that they might want to do, but they just can't because of how busy they are. Many of those primary care providers, as Mike was talking about, shortages, they're filling in a lot of different pieces and they're getting stretched extremely thin. And so if we're able to help them and fill in those gaps, that can be a lifesaver for them and retain them in those roles longer. And on my last slide, I talked just a little bit more about the benefits of telemedicine for the staff, providing educational opportunities, helping reinforce their skill sets, giving them access to specialty services that they don't always necessarily have special or access to, and being able to really help support them. So there's so much that we could talk about, and obviously I'm very passionate about this because this is what my career is. But I think what's important for you to know is that there are a lot of options out there. It's important to do your homework, know what it is that you need, know what it is that your goals are, and then go about trying to find that right solution. Thank you.
Josh, that was really great. Thank you so much. Pam, I'd like to turn it over to you to help give a perspective from an operator. So I think you may have some lessons learned that you could share with the audience.
Sure. First, I'm very pleased to be here today, and I hope that what I share will be useful. Most of us have a little bit of a toe in the water, and this could be promising to be one of the biggest game changers that we've experienced in a long time. We certainly want to get it right. So just quickly, a little bit about Seacrest. We have 4 levels of care here. We have 122 independent living apartments. We have 42 assisted living units, 26 memory care, and 58 skilled nursing beds. We also offer home care. We just got licensed for non-Medicare certified home health, and we've been around for over 75 years. We have several boards, all very passionate about our care that we deliver to the residents and our community, and we are a not-for-profit. We also have a contract, an ACO contract with Scripps Hospitals, which is one of the major healthcare systems here in San Diego. This has been very beneficial for us in terms of getting new admissions right into our healthcare center, skilled nursing. So COVID obviously threw everyone for a loop, and thanks to the donation of several iPads, we were able to start our comprehensive Zoom FaceTime program with not really telehealth, but more from a communication standpoint between residents and families who were not able to visit our campus. And this turned out to be one of the most wonderful programs that came out of COVID. We were doing about 35 calls a day throughout the campus initially. We had to hire people just to handle the program, but it was well worth it because at the end of the day, it really kept people connected all over the world, actually, with their families. Now, our campus also now has outside visits, so this 35 calls a day has sort of been reduced, but the operations that it is most appreciated right now and very, very active is both the skilled nursing center and the memory care center. And we're doing about 16 visits a day in those operations still, even though families are able to come and visit and also take their parents out. So as I said, it's been very, very good from that standpoint. Later on in the pandemic, we started doing televisits, telehealth visits, and I had the opportunity to weigh in with each of our directors, our director of nursing in the skilled nursing, our director of memory care, and our director of assisted living. And it's interesting because they all had varying experiences, but they do agree on one thing, and that is the need for additional staff to be able to make this be successful from our end. There were benefits and challenges that each of them shared with me, and it seems to be that, for example, in memory care, they really enjoyed the telehealth because it offered a quick access to the doctor and the nurse practitioner, and they didn't have to wait for an appointment. Remember, it's a very small unit too, only about 25 people that live there. But in the healthcare center, even though they would try to schedule appointments with the physicians, I'm told that many physicians would call spontaneously requesting a visit, and it was time consuming because it took a nurse away from her or his duties. The big challenge was going over all the medications ahead of the visit and scheduling the visit anyway. And then in memory care, it seemed that the psychiatrist's visits proved beneficial just from afar, but in the nursing home and in assisted living, the feeling was that it really would be better for those visits to be in a face-to-face situation. But and everyone agreed that any physical conditions like a skin condition or a diagnosis that really would require a hands-on approach didn't really work as well through video. There were some families that were concerned that the PHI information being transmitted was not necessarily safe. And again, the biggest issue was time that it took from the staff's perspective to make these things happen. So right now we're just trying to get our back to a sense of normalcy. We really do believe in telehealth and the benefits that will come from it. We just want to go back and really evaluate how it worked in various operations and what would be the best way to go forward. It's not a one-size-fits-all, as other panelists have mentioned, and it appears for us at least to have worked differently in different settings. But the one thing I believe that our senior living industry needs to consider is a lot of collaboration, which has been mentioned before, but with telehealth providers and physician groups, healthcare and hospital systems, providers of community-based services, the public health evaluators, and even CMS, so that a model can be defined that works successfully and equitably, really for all users. And I say equitably because it is a cost to a provider to participate in a program like this. And until we get into it further, we wouldn't be able to weigh out the things that Josh provided, which were all those wonderful statistics about how it really helped the operation. We've not gotten down into the weeds to that level. But a lot of the hospital systems, they have this infrastructure already in place. So I think if we were going to go forward, and we hope to, we will want to partner with a hospital system and continue those relationships. Also, I think the Department of Public Health and CMS, they need to relax their requirements around this. I know that they did for COVID. I don't know if they're going to continue those or not, but that would be helpful because they need to look at the payment models also. And I've not experienced personally whether this can reduce hospital readmissions. We haven't experienced that to date, but that would be something that we would absolutely be very interested in learning more about and how that would happen, because it's important that we as providers are able to do that for so many reasons. And then I think telehealth will really be most beneficial for those in rural communities. And I'm pleased to say that there'll also be a generational shift, because as we talk about those that we're serving today and think about those who are going to be serving tomorrow, the baby boomers, that our baby boomer group will have theoretically have had a lot more exposure to technology than those seniors that we're serving now. And that will make it hopefully a little bit easier. But I think the fact that we're going to have somebody in the home with the person receiving the services is going to be really important. I don't know that too many people can do it on their own, especially if they're frail and elderly. They're going to need somebody there. So I'm very excited that the government is putting more significant funds to help with the growth of telehealth. And I think that this is a great way to really start on one of the biggest game changers in the way medicine is practiced and how seniors will be served in the years ahead. So thank you.
Pam, thank you so much. That's such a really valuable perspective. I know you touched briefly on staffing, but I was hoping Josh and Michael, maybe you could weigh in a little bit. One of the things I always hear as a concern prior to any telehealth implementation is, what are the staffing implications? Does it change an operator staffing model when you set up a telehealth program? Are additional dedicated staff required? Or does potentially a telehealth program even preclude the need for an on-site physician or on-site clinicians? Michael, Josh, any thoughts?
Sure. So I'll tackle the on-site clinician provider first. Telehealth, in our opinion, will never fully replace on-site medical care. There's just certain things that, first of all, you can't do. And prior to the public health emergency, there's certain things regulatory-wise that still have to be done face-to-face. So we built our model around being more of a collaboration and a support to those local providers versus a replacement for them based off of many factors. And we do believe that at some degree, you still need to have some of that hands-on face-to-face care. From a staffing standpoint for the skilled nursing facility or assisted living or wherever, honestly, that's a tough question to answer because it really depends on what are your goals and what types of programs are you implementing, and then I could better answer that. In general, one thing I would have people think about, and this is a conversation I have with a lot of people when we're looking to potentially go into their business, is how much time does it take to do all of the back and forth to the emergency department or to urgent care clinics? And what is your staff doing? Maybe you're not bringing in additional staff members, but it's tying up a lot of their time. It might be leading to things like overtime, stressed workers, additional burnout, potentially turnover. And so while telehealth at the moment of an encounter may seem like it takes a little bit more of their time because you get the cart ready and you log in and you have the visit and you're there for the provider visit, in the end, it may be equal, or may in some instances actually be less. And so I understand why a lot of times people go to the mindset of, oh, this is going to take way more staff time to do this, but when you start really digging into it, it doesn't always.
Yeah, I would lean to like what Josh said, just a little bit more. A lot of times, up front, the staffing, especially like when you're this last year, I think you kind of have to say every organization that that had patients or residents, they were dealing with so many different operational changes and challenges that the capacity for change and sustained change, all of that was diluted. So this past year is like it's enough, like what Pam said, you dip your toe into it and you kind of like slam some things in and try to work it out. But if you take what Josh's previous experience is, like he's worked with hundreds of organizations, and my experience with the organizations is that indeed up front it might take a little bit more time, but that time does lessen, and for a couple reasons. One, the staff just gets used to it. They get more efficient at it. They understand how to plug it into their day-to-day, the hours, and then they also understand the gain from it. We get to keep this person here. We don't have to worry about the transfer. Like I don't have to pass it on to the next shift. I don't have to worry. Like, okay, if you have one admission and one discharge in one shift, great. But if you have multiple, you're already diluted as a clinician and an administrator. So if you could avert that by doing some upfront and kind of like maintaining the health of that person in their location, you're going to help your staff down the line. So you get better over time, and then you also really do figure out how much time is it really taking, because you might be paying more upfront, and that's what it seems like, but you're paying less down the line. The one last thing that I don't think was mentioned yet is that the staff, when they work with like organizations like an Avera or very savvy telehealth organizations, like they are getting more skilled because they're there with the assessment. They're understanding how to manage that patient, and eventually, and maybe to like Josh's dismay, that nurse isn't calling Josh anymore. They're handling it themselves.
That's really great, Michael, Josh, Pam. Thank you all so much. We really appreciate you guys serving as panelists. Chuck, I'll turn it over to you for some closing comments.
Ryan, thank you, and thank you for hosting today's panel discussion, and many thanks to Pam, Josh, and Michael for your respective insights on the need for and value of telehealth services for seniors. As a few seats remain available for the follow-up group discussion to today's leadership huddle, if you're able to join us, you're welcome to click on the Zoom link, which is now posted in this webinar's chat. The Zoom session for the group discussion will begin shortly at 2:50 Eastern and will conclude by 3:30 Eastern. We welcome everyone to join us again in 2 weeks from today on Wednesday, May 12th at 2 p.m. Eastern, 11 a.m. Pacific for our next NIC Leadership Huddle. Seniors Housing Equity Players Talk Investment Strategy. The upcoming webinar will feature a candid discussion with 3 equity capital providers on how they view seniors housing as an investment opportunity, including real-life examples of recent acquisitions and dispositions, as well as go-forward investment strategies. We also hope that you can join us for the 2021 NIC Fall Conference, taking place in person November 1st through 3rd at the Houston Marriott Marquis. Registration for the conference opens in early June. You can sign up for email notifications by going to our website, nic.org/fall2021. And with that, we wish everyone a good afternoon. Thank you for having joined us. This concludes the webinar portion of today's Leadership Huddle.